Hi everyone, I'm Stephanie Fullerborn, stationed at Eglin, and this study is about how family physicians discuss and document diabetes remission. These are our authors and our obligatory disclaimer. In 2009, a consensus statement was published in Diabetes Care, which recommended that we view diabetes as a chronic illness that could go into remission. Definitions of complete remission and partial remission, which has since been called regression, were proposed. Since then, multiple studies using these criteria have demonstrated the incidence and attainability of remission of type 2 diabetes. Around the same time, the ADA introduced prediabetes as a diagnosis, establishing a continuum of glucose intolerance. Ever since, there's been mounting evidence regarding the risks associated with prediabetes, primarily cardiovascular disease and death. The idea of regression of prediabetes to normal glucose regulation is now under study as well. Patients also identify the absence of disease as a treatment goal. In one national survey, research regarding the reversal of diabetes and ways to identify individuals with prediabetes were the top two priorities. As evidence for the identification and treatment of prediabetes grows, we need to understand current practice patterns so that we can identify gaps that may affect patient care. Remission can be empowering for patients, rewarding for physicians, and could result in decreased overall costs to healthcare systems. It is unclear if physicians document or discuss remission of prediabetes and type 2 diabetes. Our study aimed to address these issues. This was a cross-sectional survey, part of the larger omnibus survey. All registered physician attendees were eligible. We wrote case scenarios followed by multiple choice questions with a single best answer. Ultimately, 284 physicians were included in analysis, and demographics of the respondents are presented here. A prediabetes case scenario was presented. We considered the ICD-10 codes chosen to be surrogates for documentation in the EMR. 70% of those surveyed correctly recognized and documented prediabetes. In a logistic regression model seen here to predict correct diagnosis, the only significant predictor was greater percent of time spent in clinic. Only about 60% of those who documented prediabetes indicated that they would use the word prediabetes in discussion with the patient. In the prediabetes follow-up encounter, the patient had an A1C of 5.2% and a fasting glucose of 99 after lifestyle changes alone. Nearly 60% of the physicians who documented prediabetes in the initial encounter indicated that they would not have charted any diabetes-related code in follow-up, reflecting the patient's return to normal glucose regulation or regression of the disease. We presented similar case scenarios for diabetes. 90% of physicians documented type 2 diabetes in the initial encounter. Less than 15% of those documented regression to prediabetes in the follow-up encounter, in which the patient had an A1C of 6.2% and a fasting glucose of 124, achieved through lifestyle interventions alone. Over 80% would have charted type 2 diabetes again. In a chi-square test, we found that family physicians are more likely to document regression of prediabetes as compared to regression of diabetes. Of the 118 physicians who documented regression of prediabetes, just over 60% would not use the words prediabetes or diabetes to explain the results in follow-up, which we considered to be communicating regression of the disease. Nearly 90% of the 38 physicians who documented regression of type 2 diabetes would still tell the patient, "You have diabetes." Only 6 of the 256 who documented type 2 diabetes in the initial encounter would use the word prediabetes in follow-up. Our finding that a majority of physicians would document prediabetes may not represent actual practice. In a recent survey, nearly all family physicians identified prediabetes by A1C on a quiz, but only half of their patients with prediabetes had the diagnosis in their charts. In other reviews of EMR data, a diagnostic code for prediabetes existed in less than 1 to 13% of charts of adults meeting criteria. This communication gap may be due to lack of consensus regarding diagnostic thresholds for prediabetes, or to the contested nature of the diagnosis itself. Regardless, these practice habits are likely contributing to the fact that nearly 90% of adults in the U.S. who have prediabetes are unaware of their diagnosis. This represents a missed opportunity to prevent complications associated with prediabetes, among them premature death, cardiac, and cerebrovascular disease. Several long-term, large-scale intensive lifestyle intervention programs have demonstrated significant reductions in the rate of conversion from prediabetes to diabetes. From a military medical readiness perspective, this is critically important, as diabetes is a potentially disqualifying diagnosis for service members. There's evidence that recommending lifestyle changes leads to increased physical activity, weight loss, and even return to normal glucose regulation in patients with prediabetes. For these reasons, the ADA recommends that patients with prediabetes be informed and counseled appropriately. We propose that naming the diagnosis using the term prediabetes is important to communicate a clear message of the current disease state, its associated risks, and a path forward. Overall, the majority of physicians are not documenting or discussing regression or remission of these diseases. This may be due to lack of awareness of the possibility of and criteria for remission. Though recent studies have demonstrated remission through lifestyle interventions, as discussed earlier, prediabetes and diabetes are almost unanimously regarded among physicians as lifelong diseases. Physicians may be appropriately reluctant to document a lesser diagnosis than type 2 diabetes when proposed criteria for remission are met, as the evidence for long-term outcomes in the medical literature is lacking, as compared to surgical literature, where evidence of improved long-term outcomes is more robust. Though there is an ICD-10 code to document remission after bariatric surgery, no such code exists after lifestyle changes alone. This presents a very real barrier to documenting the clinical status of these patients. In summary, we propose that patients should be informed of the diagnosis of prediabetes, its associated risks, ways to prevent progression to type 2 diabetes, and ways to achieve remission. Physicians should discuss and document the possibility and the achievement of remission of both prediabetes and type 2 diabetes with patients, as this can motivate change behaviors. And we have identified several barriers and areas for future research, which are further expounded upon in our paper. Our references are here. Thank you for listening.